I can get everybody to sit down for a second. We'll see if we can get started here. I know folks are still trickling in. Stuffed myself with croissants. Are there any cardiologists here? I need an extra Lipitor if I can find one. My name is Brian Kelly. I'm the editor and chief content officer of U.S. News and World Report. I will be the host and moderator for our discussion today. We are very happy to be back at Mount Sinai. We were here a year ago for a very similar, very thorough and useful discussion about medical school rankings. At the conversations we've had with the folks at Mount Sinai, we thought the next most important topic for us to address was the hospital rankings, U.S. News's hospital rankings that we've been doing for more than 20 years, but also more broadly than the rankings, our role as a data provider in the healthcare space. We obviously, a lot of people focus on the top of the rankings, and we will dissect them and talk about them, but we also have done a variety of things and are continuing to do more things in the area of health information for consumers and also working with institutions. And we see ourselves as part of a transmission belt of information. It's not a one-way street. It's not about us slapping up a 1 through 20 ranking and walking away from it. We very much are a participant in the healthcare community, and our primary audience is consumers. Our primary function is journalistic. We are trying to get the best information we can get and provide it to people to help them make decisions. But obviously, we are deeply involved in many of the complexities of the medical world, the data side of it, which continues to grow and become more important. So with that thought, we are looking for a dialogue. We are looking for feedback. We always seek feedback on an ongoing basis. But here we have a particularly great opportunity with some extremely accomplished folks from the medical field, from many aspects of the medical hospital field. And we're hoping to have a very robust conversation here that will be useful for everyone. So with that, I would like to, I do need to say, I've got my producer has said that we've got a few housekeeping matters that we want to make everyone aware of. So the summit panels, we will have Q&A opportunities, and we're very interested in hearing from folks here in the audience. There'll be a microphone over there, and if we can just ask you to queue up and go from there. This is being live webcast, so anyone who wants to ask a question, please be clear and state the question concisely, and think in terms of TV here. We also have a Twitter stream, a live stream, hashtag Best Hospitals, and we'll be looking for some input on that, from some questions, and using that as an opportunity to get some folks inside and outside the room to respond to it. So with that, let me please bring up Ken Davis, President and CEO of Mount Sinai Hospital.
So good morning, everybody, and welcome to what I think is really an extraordinary gathering. I want to thank our friends at U.S. News for their sensitivity and their ability to take the kind of feedback that they have heard before when we did this for medical schools, and we will undoubtedly hear today. It's no surprise to us that this is the most valid methodology, because these people are so sensitive to the kind of work that they do and feedback from people like us. So I'm going to use my prerogative as host here to offer a few thoughts and suggestions that might guide some of the discussion today. This is not working. This is a bad start. There we go. So let's just remember why we're here. These healthcare rankings are very important. They're used by consumers to make what they think is the best choice of where to go for their most complex care and their routine care. The rankings are increasingly holding hospitals accountable for outcomes, and they create transparency more than there has been in a very long time around healthcare data. And these are all good things. But there are a plethora of ranking systems, and I would argue that they're not all created equally. Let's just look at two, for example, and contrast them with U.S. News and their best hospitals rankings. Consumer Reports use the lists of hospital-acquired infections, readmissions, mortality, patient experience, whatever they mean by that, and the evidence of duplicative CT scanning to come up with a ranking. And they come up with some interesting results. In New York State, for example, the leading hospital was Peninsula Hospital, a hospital that at the time that the rankings were published was in Chapter 11, was being closed, and shortly thereafter was closed down by the state for safety reasons in their clinical laboratory. Obviously, a problem here with the validity of that rating scale that would come up with that kind of result. Most recently, we've seen JCAHO's results. Process-oriented, also uses some of the same markers that Consumer Reports did. I hope in our discussion, as I will point out, heavily influenced by some socioeconomic variables. And what we find is that the leading academic medical centers across the country don't make the list. Johns Hopkins, for example, which I would think arguably is certainly one of the best hospitals in the world, is unable to find itself on the JCAHO list. So what does that say about the validity of that method? In contrast, I would challenge anyone to look at the best hospital list of U.S. News World Report and not think that there is some face validity there among patients, patient advocates, leaders in academic medicine, and leading physicians. The question then is, why is this so much better than the others? And I would argue that it's because their methodology is fundamentally sound. And these are the components of their methodology. 32.5% driven by reputational score, another 32.5% driven by the Medicare Mortality Index, and 30% from these items that we call structure, and that includes a series of factors that I'm going to go into. But most notably, we'll talk today about technologies and patient services. And then there's also 5% for the Patient Safety Index that's given far more weight in some of the other rating scales. How I would like to focus our conversation today, and the suggestions that I'm making, is that we look at these areas to potentially sharpen up the existing methodology. That is, to find a way to recognize those most innovative healthcare centers, to take some account of socioeconomic variables and their impact on patient outcomes, to look a little more deeply than current MedPAR data does at comorbid conditions, and to look at the challenges of post-hospital care and its impact on mortality statistics. Let's begin with current measures of innovation that are included in the U.S. News methodology. We have technologies, and on the right we have services. Services are not evenly weighted. These things on the right are not all equivalent. Those on the left are given 1 point in the scale equally if you have these. I would argue that among all those technologies that you saw here on the left, that they might not all be weighted equally, that they're not all equivalent, that some really are more important than others, just like some services are more important than others. And I would also argue that some things that are not included, like IT capability today, is extremely important. The degree to which a hospital has an electronic medical record and it's wired to its patients, the degree to which it can perform sophisticated data mining tasks and provide decision support for its physicians really does separate hospitals, and I would say should be an important part of this methodology, but let's talk about that this morning. I also think it's important to recognize, and I say this as someone who led one of the first Alzheimer's disease centers in the country that was recognized by the NIA, that those designations, like the Alzheimer's centers, like the cancer centers, are not all merit-driven. They also have an important part of geography. As I sat in subsequent meetings that designated other Alzheimer's centers after difficult reviews, we pointed to large parts of the country that simply didn't have an Alzheimer's center and said something's got to be done there. So it's not always the most meritorious places that get those designations. And I would also remind you that just most recently, Kansas received a cancer center. Now, they don't have a cancer center there, and that's probably a good thing. But one might also argue that it's perhaps not happenstance that the head of HHS is from Kansas. There are other areas of innovation that are rapidly overtaking us in medicine that are becoming extremely important. And I think in precision medicine, or personalized medicine as some call it, genomics is increasingly valuable. I imagine that at least half this room read the Steve Jobs biography by Walter Isaacson. And you remember that Jobs had the ability and the wealth while he was dying to get the genome scanned of his cancer. Well, we know that's becoming very inexpensive, and genome scanning of cancers will increasingly become a standard of care in the next few years. Those centers that have the greatest capability in genomics, who are already using genomics to make decisions about patients, I would argue might constitute some of the best hospitals in America, and we should think about how that too could be included. And I'd also like us this morning to realize that patients often come to hospitals for the therapeutics of tomorrow, for experimental therapeutics, for the next generation of drugs. And they're going to come to those centers that have the most clinical trials, particularly the ones that are NIH funded. And there's data that is available on what are the NIH funded centers. Patients need up-to-date data when they come and make decisions. In 2012 rankings, we will use data, US News will use data that comes as late as 2008. The question that I think we need to discuss this morning is whether a 2-year window might give us more precision than a 3-year window. Now, patient safety index is one way, and just one way, to get a window into socioeconomic factors and how it affects patient outcomes. These patient safety index measures and many similar outcomes are deeply affected, as this slide shows, by socioeconomic class. For example, the difference between patients with private insurance, and this comes from AHRQ data, and patients on Medicaid in a number of these measures are enormous. And if socioeconomic factors aren't considered, the kinds of outcomes that we saw in the JACO result and the Consumer Reports results are inevitable. And these really skew, I think, the utility of these measures. 5% of the US News, only 5%, uses the PSIs. But I would still think it's worth discussing today whether a Medicaid burden that is substantial on a hospital produces a hospital that is substantially different than a hospital that has, say, 1 or 2% Medicaid, and that we need to somehow adjust for the fact that these patients are patients that require more work, more effort, and will have inevitably a different outcome. The mortality index is used across all rating scales. This one that comes from US News is the Medicare, it comes from Medicare data, the MedPAR data set. An index of less than 1 for the actual or observed versus expected mortality is good, and greater than 1 is bad. But I'd like to point out and like to let us discuss how for some conditions, MedPAR data doesn't fully address comorbidities. And as an example, but only one example, I'm going to talk about transplant, although what I'm going to talk about applies to not just solid organ transplant, but bone marrow transplant. It accounts for patients who are getting radiation therapy. It accounts for patients who are getting infusions of oncological medications. It accounts for people who have poor housing situations, and it accounts for people who are on palliative care. So this is just more than transplant, but I'm going to use transplant as an example. In the case of Mount Sinai, for example, we're going to make this very specific. If we didn't include transplant services in our GI numbers, our index of mortality would have improved by 25%. Why is that the case? That's the case because the current MedPAR database takes a patient who is in need of a transplant but comes into the hospital for, say, pneumonia, and doesn't fully adjust for the fact that that's a patient who needs a transplant. Similarly, it doesn't adjust for how many days patients may be waiting for a liver. In New York or California, for example, patients going to wait on an average of 750 days before a liver transplant occurs. In Florida and Washington State, it's a fifth as long. One can't conceive that a patient who has waited 750 days should have the same anticipated mortality as a patient who's waited 150 days. But yet, that's how they're treated in the MedPAR data. So we would suggest that some consideration in transplant programs be given to the length of stay, the length of time between people getting transplants and getting on the list, as well as to use the V codes. Because the V codes adjust for issues such as whether they're a transplant patient waiting for transplants, whether they've been treated with radiation and chemotherapy, patients receiving palliative care, and this V60, patients with challenging housing circumstances such as homelessness or living alone. Clearly also a marker of socioeconomic problems. Another problem with the mortality index is what happens after a patient is discharged and how long it takes for people to enter post-hospital circumstances and post-hospital services. Take a look at the difference in the availability of post-hospital beds, nursing home beds, hospice beds, other post-hospital services for people in the District of Columbia, New York, Rhode Island, and Oklahoma, Utah, and Oregon, for example. As a consequence, and we know this, it's very difficult to get a very sick patient discharged from hospitals in New York into a nursing home for appropriate care. A 30-day window for mortality as a consequence is really quite different for patients who are living in these areas on the left than these areas on the right. Because the, in fact, period in which people could have a mortality is really far longer for people who spend an extra 2 weeks in the Northeast than they do in the West and the Midwest. So we would suggest that we need to adjust mortality for some geographic differences in access to nursing home and palliative care. So no ranking is perfect. And as I began, I said this methodology is certainly superior, in my estimation, to others that are out there. And even more noteworthy is this methodology is open to feedback from people like us. So in conclusion, I hope that I can focus today's discussion just very slightly to consider how we can better take account of innovation, of IT, of genomics, of the time frame that we use to evaluate hospitals, whether 3 years is really too long, to take a harder look at the impact of socioeconomic variables, to include V codes, at least to discuss the use of V codes, to think about the length of time people stay on waiting lists, and to deal with the post-hospital issues that so confound a lot of the care that we use, what we have in urban northeastern areas. So thank you, and I turn the program back over to Brian now.
Live here. Thanks. Thank you, Ken. Thanks for that, and thanks for the very thorough preparation that went into that. We did a similar session to this 2006, 6 years ago, where we brought together a like group and dove into some of these very detailed issues, and you can see the depth of what goes into those rankings and also the questions that can be raised. It's very important things in multiple areas, and so I brought up Avery Comarow, who is our the editor of our rankings in many ways, the godfather of the best hospitals rankings. And with Avery and in the audience, we have a number of the key members of our team, which is really quite extensive. We have a variety of folks who we've worked with for many years. So I'm going to, Avery, ask you just give us a quick overview of a few of the folks who are with us today too, in terms of our backup.
Our contractor for these rankings is RTI International in North Carolina. We have We have Murray Olmsted, Dr. Murray Olmsted here, and Emily Geisen. Murray is the project director. Emily is the number two. We also have Steve Sternberg. I think he made it up from DC in time. He's the deputy health rankings editor for U.S. News. Megan Johnson has been instrumental for some years in coordinating the production of these rankings. Ben Harder, my boss, is always pushing to extend the rankings, as we intend to do, to make them better, as I also want to do, and he is most definitely here today.
Great. So we want to make ourselves available, whether it's sitting up here formally or informally, and certainly in terms of follow-up after this. I think Dr. Davis was kind enough to say that we are very open to a dialogue and to change. It's not like the rankings have been static, and as the marketplace changes, the availability of data changes, we are receptive. Avery, tell us a little bit about why we started these rankings and how that methodology evolved.
This was an order from the owner of U.S. News back in the late 1980s. He was and still is on the board of Memorial Sloan Kettering. He's a lay person. We're talking here about Mortimer Zuckerman. He knows very little about medicine, and because he was on the board, friends and family would continually ask him if they were in trouble, what they should do. And he would get frustrated because he had no answers for them. And at the time, I was running the consumer section of the magazine, a section called News You Can Use. He came to me and said, "Thou shalt," meaning create some sort of way for me to tell people, for U.S. News to tell people where they should go when they are in trouble, meaning not your average hospital patient, not somebody who needs relatively routine bypass surgery, if there is such a thing as relatively routine bypass surgery, or a hip replacement or spinal fusion or a hernia operation, but somebody who is in trouble. He didn't know how to define that, but I think we do. Whether it's a collection of comorbidities or a very difficult procedure or whatever, that's what he was talking about. And I said we couldn't do that because there were no data. Although at the time I said there was no data because I didn't know any better. And he looked at me and gave me a Mort look, an owner look, and it happened. In 1990, we launched Best Hospitals strictly on the basis of a reputational survey in 12 specialties. In 1993, working with the predecessor, the contractor prior to RTI, the National Opinion Research Center at the University of Chicago, a data-supported methodology was created, and that is essentially the same methodology that we've used up to this date, expanding it to 16 specialties, moving into children's hospitals with its own methodology based on data almost entirely collected from the children's hospitals, but maintaining that original focus of patients who need the highest and best level of care.
The hospital rankings have evolved, starting, this is our latest print product, and it started in print, and for many years was only in print. And there are limitations to what you can do in print, but I think the real breakthrough for us came when we put the rankings online. And as we had done with our college rankings, it became evident that the amount of data that we had, that we were capable of publishing in a print publication, was very limited. But the amount of data that we had was vast. And a lot of what has become the new I think the new influence of the rankings is due to the internet, where we're now able to serve an enormous audience. Tell me about how big that audience is and how we publish that data.
I actually don't know how. I don't look at things like web traffic and
it's millions
and views. It's probably billions and billions. what it has allowed us to do is to extend the rankings beyond the original 50 per data-supported specialty down to well over 1,000 in some specialties when we decided to go below the line and give people information about hospitals that are in the top quarter of all hospitals nationally, using exactly the same standards as we do for the top 50 ranked hospitals, but deepening the amount of data that we provide so that people can see. I don't remember offhand, Murray and Emily probably remember roughly how many hospitals were eligible for ranking, for example, in cardiology. It was probably something like 1,000 or so. Meaning that although only the first 50 are ranked, you can get exactly the same data on the other 950 or so. Any hospital that is eligible for ranking by meeting some basic eligibility standards and volume standards is now included online. Clearly, we could not, in 16 specialties, have run anything close to that before. I think that's the single best example, and it gives us an opportunity to go beyond that and to extend the utility of the rankings or the hospital data to even more routine procedures and conditions that we'll talk about later.
Yeah, good. Among the revelations about our audience is the number of international folks who come and look at it. It's a truly global ranking now. The brand of U.S. News and what it has done to project these various institutions globally has been, significant, and I think in our view very satisfying in terms of what our mission is. But then the other aspect of it, I think, in terms of the internet is fundamentally a ranking medium. If you think of what Google is a rank. It's a ranker. That's what it does. That's good. That's both good and bad because there's a lot of crazy rankings out there. But I think as our influence has grown, it has also caused us to look in the mirror a little bit more closely and say our responsibility has grown. So, talk about the interaction that you have, Avery, with healthcare providers and hospitals and some of the work that RTI's gotten engaged in.
We've always been open, as Dr. Davis made clear, to comments and criticism and suggestions from the outside, and not just for its face value, but because we think that nothing improves like dialogue can. In 2006, we brought together 50 quality and safety clinical experts and medical providers. There may be a few people here today who were there in 2006 for a full day of brickbat throwing and suggestion making, and at the end of that day, we came out, I think, stronger, better, more committed, and because of that day, there were some very specific changes we made. We created the separate pediatric rankings, partly because we were so surprised to hear at that session that they felt that if we could do a job that had face validity, again, to use Dr. Davis's term, with adult hospitals or adult specialties, then why shouldn't we be able to do that with pediatric specialties? And so we split apart the pediatric rankings from best hospitals because at that point they'd been based entirely on reputation. RTI went to work and created a methodology, and today we have a separate brand, a separate set of rankings, a methodology that is based only at its most fundamental core on the methodology used in best hospitals. It is its own. And there were more specific, more detailed suggestions made. We have suggestions coming in all the time by email and phone calls. We have working groups that are set up for pediatrics. We have advisors who we consult. This is not a black box operation, and we don't think it should be, although the entire purpose from my perspective is and should continue to be to provide patients with a tool that they need when they need it. That doesn't mean that we can sit back and in some sort of monkish way develop an isolated set of ways to to do that. So the engagement is ongoing, it's constant. I think that Murray and Emily can, if they had time, could speak for quite some hours on the suggestions they get, and each one is taken extremely seriously, and you might be surprised how many of them, in one form or another, are implemented into the methodology.
In any ranking, and as you know, we do many rankings, colleges, I see Dennis Charney here. Dennis, hi, we had a great discussion last year about the med school rankings, law schools, business schools, et cetera, and we, to the extent that we can, we continue to expand and look for other things we can rank and sort that way. The limitation to do good rankings, the prime limitation, is the availability of the data, the availability of good and comparable data. Was that great event that HHS had, Chad, what was it, when was that? Datapalooza. The HHS was releasing, they have so much data now, the government has kind of gotten data religion, and they've gotten they want to start pumping things out, and there's certainly cautionary tales there, but there's a flood of data, particularly healthcare data, that's becoming available. So we're very intent on being able to take advantage of it to the extent that we can, but being responsible about it. Talk a little bit, Avery, a couple things. The evolution of children's hospitals and what it took us to get that data, and what our experience has been with the hospital community about trying to get perhaps other data sources made available to us.
Children's hospitals couldn't have happened without the cooperation of what's now called the Children's Hospital Association. Back then it was NACRI, the National Association of Children's Hospitals and Related Institutions. They felt that it was worth partnering with us, providing us with what data they had, and urging their members to cooperate with us if we wanted to reach out to them to obtain information. And we realized with children's hospitals that the major challenge would be the almost complete lack of benchmarks, guidelines, protocols, and just plain databases, whether there were, threshold levels or not. And what we had to do, and when I say we, of course, I don't mean U.S. News. I mean Murray Olmsted and his and the people we worked with at RTI, was to create working groups to help us bring this together. So there was a working group created for each of the pediatric specialties we had in mind. They proposed outcomes measures and other measures that would play into the methodology, and they were all sorted out, and we did that for a couple of years, and it just happened, and it's continued to improve. We continue to have those working groups, and they continue to provide input. The problem with the adult hospitals and data is that so much of the data is available only in limited forms or irrelevant forms for our purposes, or not available at all. Our franchise, as Brian, I think, makes clear, is to provide a seamless web of health information. If we could, we would go all the way from provider, whether the provider is a doctor, a hospital, or any other healthcare provider, all the way through to insurer, as we have started doing, and give consumers those tools that they need to make choices. Right now, those choices are not fully available for doctors because we don't have performance data, and the National Physician Database is not open and available to us, and some of the data would be irrelevant. For hospitals, we know what the only national database is right now, and that's MedPAR. RTI does a terrific job, if I understand the methodology correctly, using various measures to extend the Medicare population data beyond 65 and over, to make it more applicable to a broader population, but it still doesn't reflect, obviously, things that affect younger people. We would like to have access to all surgical data, all procedural data, all condition data. If I can make one point here, you know, one of the bullet points that Dr. Davis had up, I think his first or second slide, was that one premise of all of this is to hold hospitals accountable for income, for outcome.
That's a different panel that we're doing. That's for the CFOs. No, not today.
You see what you hang around with anyway.
Yeah, I've been corrupted. He knows that.
And that word accountable is real interesting. I think a book just came out by Marty McCary, a surgeon at Johns Hopkins, called Unaccountable. Some of you may have seen it. It's quite a book, and he did a long op-ed piece in the Wall Street Journal this past Saturday, and I want to read just 3 sentences from it. And it really is the premise for speaking for me and the point of doing hospitals and the point of extending what we do. What he said in his op-ed piece was that hospitals as a whole tend to escape accountability with excessive complication rates, even at institutions that the public trusts as top-notch. Very few hospitals publish statistics on their performance, so how do patients pick one? Every hospital should have an online informational dashboard that includes its rates for infection, readmission, what we call bounce back, surgical complications, and never event errors. The dashboard should also list the hospital's annual volume for each type of surgery that it performs, including the percentage done in a minimally invasive way, and patient satisfaction scores. A survey of New Yorkers found that approximately 60% look up a restaurant's performance ratings before going there. If you won't sit down for a meal before checking Zagat or Yelp, why shouldn't you be able to do the same thing when your life is at stake? Well, you know, you can take issue a little bit. You can start talking about complexity and how easy it is to talk about that sort of thing, but a restaurant meal isn't the same as pancreatic, dissection or whatever. But but the principle is still the one that drives us. And with perfect data, at least more data, considerably more data, we could get much farther along that road. And I would ask, I've wanted to ask Dr. McCary, I talked to him just before the book came out, and I forgot to ask him whether his own institution has such a dashboard, and we know, of course, that it doesn't. I don't know any hospital that does, that lists all of the procedures, the volume for each one, the outcomes. But here he is, a surgeon putting himself out there and saying this is what we ought to do. And I think that carries some weight.
I want to ask if anyone has questions for Avery. You're going to need to queue up behind that microphone in the aisle there. So if anyone has some questions they'd like to ask, please feel free and move over there. Avery, back to children's hospitals for a minute. One interesting thing is developed where we are actually exchanging data with the hospitals. We're sharing our data back to them, right? Tell me how that evolved and what that's meant for us and them.
Well, I think that in terms of that original notion that we would help drive performance improvement, hospitals quite naturally feel that without knowing their data, that is getting behind the curtain of indicators like indices and whatever that mask what the actual numbers are, how can they improve? So they've come to us, or RTI through us, and asked to see their specific numbers. And after some degree of internal debate, we agreed that they should have those numbers. And again, Murray and Emily, correct me if I'm wrong, but I believe that we also provide a benchmark or an average so that there's a context for those data.
There's instructions on how to use the methodology report and all the tables there to compare their data to
there are instructions on how hospitals can compare the data that we give them to the data for other hospitals, even if they're not formal benchmarks or thresholds. So we recognize that we, again, even though the tool is for patients, patients will not receive care that is improved unless hospitals improve it, and we need to help them improve it. So that's how that works.
Good, thank you. Question over here, yes, sir.
My name's Steve Silver, and I'm the medical director for safety and quality at New York Methodist Hospital in Brooklyn. And what Dr. Davis said was excellent about weighting and case mix adjustment and socioeconomic. So on the basis of the weighting and how that's figured into your methodology, I'm just wondering why 32% is based on reputation as opposed to actual hard data.
When Dr. Bernadine Healy, former NIH director, was on our staff as a columnist and health writer, one of the things that she felt passionately about was that the reputational component of the methodology mattered, that the size felt about right. She felt that the right specialists, meaning people who were board certified, randomly surveyed, should have a pretty good idea of which 5 or 6 or 7 hospitals they would send their sickest patients to. She felt that it was a form of peer review. Whether you agree with that or not, reputation is a proxy for the process component of the Donabedian paradigm. It's as close as we can come to looking inside a hospital, each individual hospital, and seeing, outcomes aside, structure aside, whether patients who come in the door are treated appropriately and come out as they should. Why 32.5%? Well, it was 1/3, 1/3, 1/3 for many, many years, and then we started factoring in patient safety and gave half of the patient safety weighting to outcomes and half to process, since you can, I think, argue persuasively that complications that arise from these incidents are process measures. Would we eliminate it completely if we could? I'm not sure. If we had better process data, we've all talked about lowering it to 20%, maybe 25%, maybe even 15%. There is no magic number, and one of the things over the years that we've moved away from is this idea that we don't need to worship at the Donabedian icon, you know, the exact 1/3 and so on. So it can change, and I'll note that for pediatrics, in fact, it's 25%. But the reason for that is because we can collect so much good data directly from the children's hospitals, including process data, and we can't do that from adult hospitals.
Thank you.
Thank you.
That's the short answer.
We're going to get a little more deeply into the reputation question with some of our panelists coming forward, so we'll have a little more chance to look at that. But we've got to move on to the next panel. Avery, thank you, and stand by because we're going to tap your expertise in the hours forward here. So, Jim, if we can bring up the next.
5 minutes.
Okay.